So hi again, everyone. If you've been with us over the last day, you already know me, but my name is Alissa Terry, and I'm a genetic counselor and the project manager for NYMAC. Today, we have a really great group of people to talk with us about Telegenetics Updates. I'd like to welcome our panel across our 10 NYMAC jurisdictions. There are 3 telehealth resource centers that we work with. Dr. Kathy Wibberly is from the Mid-Atlantic Telehealth Resource Center, Lloyd Sirmons from the Southeast Telehealth Resource Center, which covers Puerto Rico and the Virgin Islands, and Danielle from the Northeast Telehealth Resource Center. We also have Lynn Perry with us here as a parent who has received telehealth services to share some of her thoughts and experiences. So we welcome all of our speakers and thank you for being here. And we do not have any relevant financial disclosures. So during our time today, we're going to explore with all of you about your own use of telehealth. We're going to ask this group about barriers you're experiencing right now and talk about existing resources for telegenetics. We'll hear from Lynn about the family experience with telehealth, and then we'll gather new information from the telehealth resource centers about updates in telehealth practice and policy. It came up yesterday when we asked this question in the morning, what people were challenged by, and the ending of the public health emergency that is coming soon is going to create a lot of big changes to telehealth. So this session hopefully is going to really help people understand where to go, to understand what the new rules are, and just be aware that things are changing. So I mentioned on the first day that telegenetics is one of the key areas that NYMAC focuses on to improve access to genetic services. So this is a really important topic in our work, especially when we're trying to reach into rural areas that don't have a lot of providers. So it has a lot of value for rural health. I want to start by getting just a quick sense of who's with us right now and your experiences. So I want you to think about just the past 12 months. And over that past year, we'd like you to share with us approximately what % of your family's healthcare did you receive by telehealth? And approximately what % of the healthcare services you provide were done by telehealth? So you see that poll come up here. And just share what's been going on for your family and your workplace, if applicable.
You should be able to see the polls now. Yes, we already have people responding. Alissa, I don't think you can see it because you're a co-host, so I'll share the results. Great. Let's give it 10 more seconds. I'm still waiting for a couple of people to respond. All right, I'm going to close the poll in 5, 4, 3, 2, and 1. All right. So sharing the results. Can you see the results, Alissa?
So it looks like for a lot of us, we're sort of in those middle bands of somewhere between a little bit or a lot. Nobody, not a lot of people in the almost all, and some people have not had any telehealth either receiving it or giving it in the past year. But a lot of people in this room have had experiences. And then from the workplace, people are kind of spread all over the place. Some people doing it all the time still, as a lot of people were in the height of the pandemic, and some people kind of back down to none. So we definitely see that across the board with the work that we do, and people making changes to the way that they use telehealth compared to what they were doing, certainly compared to what they were doing 5 years ago, but also compared to what they were doing 2 years ago. So thank you for sharing those recent experiences. It helps us understand kind of where everyone's coming from. The challenges that many families in our region face in getting to a genetics clinic were really a big motivation for us to start exploring telehealth 5 or 6 years ago. The visuals that you see here were developed by families in our region to explain what telegenetics really was to other families before telehealth became a commonplace thing. So when I'm talking about telegenetics or telehealth, most people think about live video meetings, and that often happens. But sometimes telegenetics or telehealth happens over the phone. Sometimes records and documents are sent to a provider without a live meeting, and we call that store and forward. Sometimes a doctor will keep track of a person's signs and symptoms and send that information electronically for evaluation. That's called remote patient monitoring. And then sometimes these communications happen on mobile devices by texting or using apps or video messages, and that's called mobile health. So with our overall goal being to expand access, we definitely see from the studies that have been done that telegenetics can improve access. It can reduce cost, reduce wait time, and definitely reduce travel for patients. Even before COVID, we were able to see that there were telegenetics programs in the NYMAC region and a lot of interested providers. We all saw that telehealth and telegenetics was really important to maintaining care during COVID, and we're going to share the link for this family-friendly flyer with you in the chat. So we also know that, as we just touched on, the way that people use telehealth has changed a lot over the last few years, from the height of the pandemic now to new levels. So I'm curious from your experiences if you're already seeing that. So in the next poll, I want you to think about and share with us whether there are things that you used to be able to receive by telehealth or provide by telehealth maybe a year and a half ago, that the rules have changed and you're no longer able to do that. So are you already seeing those shifts in what you do? So you see that poll come up?
Poll is up. Great, health answers coming in. Great, thank you for answering. Let's give it 10 more seconds for everybody to read all the answers. Take some time to read through the poll. All right. I'm going to close the poll in 5, 4, 3, 2, and 1. Okay, ending the poll now.
Right.
And sharing the results.
Okay, so very few people, I think only one, saying they're doing more telehealth than they were a year ago. So that's, I think, pretty consistent with what we're seeing, that people are using a little bit less telehealth. Some people aren't seeing any changes yet, and other people seeing either small or a lot of changes. So again, I think that concept of change and kind of replanning for what telehealth is going to look like in your own healthcare or in the healthcare you provide is going to be kind of a theme of what we talk about today. So as an organization, we definitely do see things changing and how people are using telegenetics. So thanks for sharing with us what you're seeing. We know some of those changes are being influenced by the rules and the policies. And as I said, we're going to talk about that in a few minutes. So we asked a question yesterday about what were some of the challenges people were experiencing, but now I want to ask it in a different way. So you're going to see one more poll come up about which of the items that we are listing is currently the biggest barrier to your own use of telehealth.
Oh, you should be able to see it. Right, answers coming in.
The hope is certainly that NYMAC can continue to be a resource to people that are trying to use telehealth, as well as all of you learning more and being able to utilize the great resources that the telehealth resource centers have to offer as well. So it's really instructive for us to understand where the pain points are right now, so that we can make sure we're getting the resources out that people need. Appreciate your sharing.
Right, I'm going to give it 10 more seconds just to give everybody the opportunity to answer the poll. And I'm going to close it in 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. And poll and sharing results.
Great. So we see certainly some issues with licensure and legal issues, big issues with funding and reimbursement, which is, I know, true in genetics, whether you're doing it in person or by telehealth. So trying to make the leap to telehealth is even more challenging. And then people definitely here and there experiencing little challenges in most of the other categories as well. But it seems like billing, reimbursement, and legal issues and licensure tend to be the big ones. So I know those are things we're going to touch on today, and certainly things that we hope to be able to support you with as you navigate telehealth. All right. So NYMAC has really aimed to support our providers that wish to use telegenetics in a number of different ways. We do offer technical assistance. We offer education and training about telegenetics, and we offer collaborative funding. On the whole, we've seen really big successes with our telegenetics work. We've been able to impact a lot of providers through navigation, training, and direct funding, and documented over 30,000 families being seen by video-based telegenetics in NYMAC-supported clinics in the past 5 years. Our other regional genetics networks also have some really great resources for telegenetics. They have work groups, they have videos, they have infographics. I encourage you to explore those, and we drop those links in the chat so you can get out and see those other resources for telegenetics. Sometimes they're family oriented to support families through the process, sometimes more provider oriented. These organizations have wonderful resources too, so we're going to drop those in the chat. I won't read through them, but other great things that can be really helpful from some of our other professional organizations, including the telehealth resource centers. So I want to turn now to spend some time exploring the family experience with Lynn Perry. So I'd like to welcome her to join me, and the two of us are just going to have a little chat about what it's been like. So welcome, Lynn. Why don't you give yourself a quick little introduction?
I'm a little cold today, so I put on a sweatshirt real quick.
Me too.
I was like, I'm at home, I can put on a sweatshirt. Yes, hi there. My name is Lynn Perry. I live in upstate New York, about an hour south of Alissa, and we've never met in person, even though we don't live that far from each other. I'm the mom of 4 kids. Their ages 17, or sorry, forgot the youngest one, 14, 17, 19, and 21. They all have a connective tissue disorder. My oldest son has an aortic aneurysm, autism, and ADHD, and my youngest has ADHD. And most of my experience doing telehealth, well, I want to say, first of all, felt I was ahead of the game with telehealth since I am part of NYMAC, and I had we had been talking about telehealth for years before the pandemic hit. So I felt like I had resources that other people didn't have, and I was able to give them out to families as they were experiencing telehealth. So I use telehealth in a variety of ways with both. I don't use genetics too much because my kids have to be seen in person for the echocardiograms. But I do use it my kids use it for mental health and for the veterinarian, believe it or not. We use telehealth for the vet's office a lot. So, and my dog Dudley is a frequent consumer of telehealth veterinary medicine. So, all right. So as So go ahead and ask your questions. I'm sorry.
Yeah. So I'm curious from your experience, both your own, and I know that you have supported a lot of other families. What do you see as the biggest advantages for families when telehealth is available?
Definitely travel, not having to travel, particularly with genetics or any other appointments that you're going to have to get to by car or by other means. Yeah. And being able to do it in your own home, not having to get babysitter for your kid, being able to maybe include some more people. We still have limits about how many people can be in the room when you're doing these appointments. And also, veterinarian Jews. Yeah, I'll talk to you about veterinary telehealth if you want to. So that there is just a way to include more people, have less distractions, be in your own house, be more comfortable, and not having to travel is probably the biggest one for a lot of families.
Yeah. One thing that I had heard early on from some of the doctors was that some of the kids that they were able to see by telehealth at home, the kids were very much more comfortable than they would be in the medical setting, and kind of displaying their more natural skills and behaviors and things like that were really useful to the doctor to be able to see and evaluate. So that was just, I hadn't thought of that before the families brought it up.
I would definitely see that. So when you get into like a exam room, everyone's taken aback because it's an unfamiliar environment.
Yeah.
And it's hard, I think, for providers to really examine a child in the space and the time that they're given.
Yeah.
So to see a kid in their more natural environment at home, with their daily distractions, their daily interactions, was definitely an advantage for providers in that setting.
Yeah. What about limitations? So what are you missing when you don't go in person? Obviously the echocardiogram, but what
Yeah,
else?
the echocardiogram. So that has to be done. And so we
Yeah.
go to Johns Hopkins every year for that. I think some of our challenges have been really about how to connect. Like there's so many different avenues of connection. And when you're dealing with kids in transition ages, like that, you know, my youngest is 14, my oldest son, Aiden, is 19. And I still get, like, when they're doing telehealth, I'm still getting their calls. And I'm like, I'm not the patient. I want them to have their privacy and be able to take their call. Obviously, Aiden's away at school, so I will have to give them a different number. So getting all that straight sometimes can, if one, is taken away from your time, their time with their provider, but it's also taken away from the experience as well.
Yeah.
And I think also when their telehealth can be, although they're in their home setting, I think my boys have gotten comfortable being in the clinical setting after many times, not after many years. So I think that's a little bit more difficult for them to look into a screen and have the same conversation that they're used to having with somebody in an office, where there's like familiar things around, little toys or whatever that they're used to kind of playing with and kind of talking through what they're feeling while they have those things.
Yeah.
And teenagers are a different bunch. I think a lot of kids, they spend so much time on technology these days, and maybe they don't want to spend the time on the technology when they're trying to talk to them.
Yeah.
That's a big challenge for us. Not to mention state laws and all that kind of stuff. Because I have a kid who, was a year ago, he committed to Albany, but we could go to schools in New York State. We could only look at colleges in New York State because his provider, who was going to provide telehealth, was licensed in New York State, but that's the only state they're licensed in. So they themselves can be anywhere. And I think he was in Florida for a little bit, but Aiden had to be in New York State because that's where that's where his provider was licensed. And another challenge actually that I found in the last few months to the whole system is providers, a lot of providers are now open to seeing more patients because of telehealth, which is wonderful, right? But at the same time, some of the, like, for instance, Medicaid providers, well, my son doesn't qualify for Medicaid, but his clinic decided that they were going to drop him because thinking he could use the Medicaid clinic, even though he doesn't qualify for Medicaid, and use telehealth there at the Medicaid clinic, what we call the Article 16 clinic. And there's not a lot of communication between different programs that are Medicaid versus, his mental health clinic. There was no communication about whether my son would be able to be seen at the other clinic, even though they've expanded because of telehealth. And the answer is no, he still doesn't qualify for Medicaid. But we were in the other situation where his main provider of services has left and gone strictly telehealth. So we were able to use that connection with Dr. L to make sure Aiden was still getting the telehealth he needed or getting the services he needed.
Yeah.
But it was kind of a unique experience. I don't think even I talked to you about that, but that was something that's happened over the last few months is expansion of services via telehealth and no communication about who would qualify for certain programs under telehealth and who wouldn't. Right. And then there's just such a waiting list actually for mental health services. So they're trying to clear their waiting list anytime anyway. But that's been a challenge.
Yeah. When you think about what it would be helpful for the doctors or the providers to know about what families are going through, what they're experiencing when they're trying to use telehealth? What would you love to like open the window and show the providers so that they can better understand what it's like from the family side?
I think families are, particularly families who are new to like genetics, to any kind of service, they're already they're already nervous about the whole situation. To begin with, I'm just going to close my, never mind. I was going to, you guys still there? I'm sorry, it closed out real quick. I think that just understand that there's a level of technology that many patients are adapting to or getting used to, that from the first moment, they're thinking not like, am I going to go into a room? They're thinking, can I connect? And that starts off your appointment and makes you a little bit uneasy to begin with. And then when you finally connect, you're like, that's a big hurdle. And then you can get into the appointment. And if you're comfortable using the technology, then that's great. But a lot of patients are not comfortable using technology. A lot of people don't have broadband. A lot of people don't have the technology, aren't comfortable using the technology. So they're dealing with those kind of issues in the background while still trying to help their have the appointment for their child.
Absolutely. Yeah. And I know that the telehealth resource centers are pretty tied into the rural health networks as well. And that's a continuing issue that I know people have been working on, the broadband issue, and that not all families have access, and there's sort of different opportunities sometimes where families can go somewhere else in the community for their appointment or things like that people have been working on, but definitely an issue, especially in the.
I actually remember when we first went into COVID, and I was on a meeting with providers, and some provider was upset at families for taking their appointments in the Walmart parking lot because they were upset over the patient confidentiality. And myself and another parent are like, you do what you can, if they're in the Walmart parking lot and they're getting broadband there, then at least you're getting to see them and you're getting to have that conversation with them. We think of, a lot of times we're thinking of broadband or communication issues in rural areas, but in urban areas, they have them as well. A lot of families don't have access to private internet, so they go to where they can, which in a densely populated city, say New York City, is going to be hard to find a private area that they can have it. And a lot of them don't know what resources are out there for like libraries and health departments that provide them a safe space to be able to talk to providers. They don't know that. So they're just on the street in a busy section, getting somebody else's Wi-Fi so they can have this conversation with a provider. And sometimes the providers aren't really, they're distracted because obviously everyone's going to be distracted in that environment.
Yeah, absolutely. Well, I know that Family Voices has done some work around supporting families in the use of telehealth, so I'll try to share those resources. We're going to transition now to hearing from the telehealth resource centers a little bit, but then we'll all of us come back together at the end for questions. So thank you, Lynn, for sharing your family's experiences. And I, at this time, am going to bring up my other colleagues. So as I mentioned before, let me share my screen so you can see their slides. There we go. Okay. So the telehealth resource centers are also federally funded organizations, as NYMAC is. They provide assistance, education, and information to organizations and people interested in providing healthcare at a distance. We have 3 people here from the telehealth resource centers, and I would like to welcome Kathy, Lloyd, and Danielle.
Hey there.
Hi.
I'll start looking in a second. Yeah.
All right. So are we ready to get started, Alissa?
Yeah.
All right. So I think, I believe I'm up first. So, just this slide here just kind of speaks to our disclaimer. The information that we provide is for educational purposes only, and is not to be regarded as legal advice. And then, also we don't have any relevant financial interest or anything like that with any organizations or products that we may talk about here today. So But I'm Lloyd Sirmons. Just to give you a little bit of a background, the Telehealth Resource Centers are federally funded entities. We're actually funded by the Office for the Advancement of Telehealth. And you know, I could spit out a bunch of acronyms right now, but that won't be helpful for you guys. Just know that we're federally funded. We're funded for the purpose of advancing telehealth and telemedicine. There are 14 telehealth resource centers, as this map shows. 2 of those organizations are national organizations. CCHP deals with policies around telehealth and telemedicine at the national level. And they do a wonderful job as well, keeping their finger on the pulse of really what's happening at the state level. They have a legislative tracker that you can access that keeps track of policies and things that are happening in the individual states. And then they also do a 50-state Medicaid report that comes in very handy when you start, you know, if Medicaid's a payer that you, a population that you provide services for. TTAC is the Telehealth Technology Assessment Center, and they deal, as their name says, with technologies around telehealth. The remaining 12 telehealth resource centers are regional entities. So those of us who are with you today, we represent some of the regional telehealth resource centers. I deal more with the southeastern portion of the United States, and which now includes the islands of Puerto Rico and the U.S. Virgin Islands. And so you can see Danielle, Kathy, and myself, we pretty much have the eastern portion of the United States covered. So you can move on to the next slide. So I just have one slide for you today. So, but just wanted to make a comment to Lynn. You know, I really, it's always great to hear from the patient's perspective, someone who's actually using telehealth, whether for themselves or for their family. But as she was talking about, you know, her, you know, using it for the vet, I was curious. I wonder if we could maybe get the perspective of her dog and what her dog thinks of the telehealth visit. But I don't think that's possible. But we did some work back a few years ago with the University of Georgia and their veterinary school around implementing virtual care. We have done some work with their agricultural school as well. So there's a lot of uses for the virtual piece and the technology piece, even kind of beyond the delivery of healthcare for us, you know, as people. And so it's always great. There's been a lot really going on recently, of course, around telehealth and telemedicine. The last, you know, the last 3 years, we've seen a lot of changes that have come down the pipe when it comes to things like reimbursement around telehealth and telemedicine, licensure. I know there was a question earlier about licensure, and you know, when you deliver healthcare in person, you have to be licensed in the state where you're located and providing services. That's a little bit different when it comes to the virtual care piece, because when you're doing telehealth or telemedicine and you're delivering care virtually, license is actually where the patient is located at the time of service. And so that's one of the big things that we saw with the whole, you know, with the public health emergency, as students were coming back home from school. And, you know, the great thing about the technology is it allows us to actually, you know, you're no longer bound by the geographic barriers when you're providing services. And so, you know, providing services across state lines, even, you know, in other countries, so forth and so on, that's very doable with the technology. And so licensure really became a little bit of an issue. So of course, with the public health emergency, we saw multiple waivers come out from a Medicare standpoint that really kind of opened the doors for reimbursement for services that were previously not reimbursable. We saw the doors open for other providers to provide services that Medicare traditionally And then Medicaid as well was not, they weren't paying for. And so, so what we see now as we're coming out of the public health emergency is we're seeing these things change. So what came to light was anything that's implemented during a public health emergency, changes that are implemented, like the changes to Medicare reimbursement and things like that. Once that public health emergency ends, those changes revert back. So there's been a lot of things that have kicked into gear with now the end of the public health emergency. So the public health emergency, as you can see on this timeline, the public health emergency ends May the 11th. That's going to cause some changes to take place, some immediately after the public health emergency. Some changes will happen, a few months down the line. For example, the Consolidated Appropriations Act of 2023 extends some waivers out through December of 2024. And then some things that were made that were changes, some things that were changes during the public health emergency, some of those things are going to be made permanent. So some of those changes are permanent. It's important to understand, and this is something that we run into a lot with people, is understanding that what we see a lot of out in the news and things of that nature deal more prominently with Medicare reimbursement. You still have to know the reimbursement and the policies, the rules and regulations of your individual state, because typically your Medicaid policies, Medicaid is governed by the state. Telehealth rules and regulations and policies are governed at the state level. So anything outside of Medicare and what Medicare does and their policies and their reimbursement, you still need to know your individual state's policy. So what does your state Medicaid policy look like? What does your private payers policies look like? Saw a question about licensure, and we talked briefly about that. So you have to know what the licensure policy is, for doing telemedicine. What's the private payer policy? Some states and more states now, like we are here in Georgia, are we're parity states, so we have parity legislation. And another thing that I noticed somebody mentioned a little bit earlier ago about the broadband. So now we hear the term broadband desert. And one of the things that we've seen is that, we realize that in areas where we see lack of broadband, that ties together and ties in with a greater health disparity. So these communities where they lack broadband, we see higher health disparities, because there's a lack of access as well. So these are all the things that we're dealing with right now around telehealth and telemedicine. And so as we move closer and get closer to May the 11th, we're seeing some changes that are coming down the pipe. And it's important for those who are doing telehealth and telemedicine, because there's some policy changes that were adjustments that were made. And there's going to be further adjustments come May the 12th. And so Kathy and Danielle are going to talk a little bit more specifics around things like HIPAA security, and then also the prescribing of controlled substances, for example, via telehealth and telemedicine. And so with that, I'm going to turn it over to my colleague. I think next, Kathy is up. And so Kathy, I'll let you have the floor.
So there are a handful of things that we know are going to change pretty much either at the end of the public health emergency, or we have a defined date when it will change. And there are a lot of things that are still giant question marks, because policy is a moving target right now. And I've done like presentations on the end of PHE for the last 4 months, and usually I do a presentation and 3 weeks later something changes and I have to go back and go, hey, but by the way, what I told you about this, the date has changed. So just know that there is a little bit of a moving target at the moment. One thing we do know for certain is that at the end of the PHE, the HIPAA enforcement discretion is going to end, but they've given you a 90-day grace period. So it was supposed to end on the day of the end of the PHE, and now the OCR has basically said you have a 90-day transition period where you have to then get in compliance with HIPAA. And many of you probably got into telehealth prior to the pandemic, but some of you probably got into telehealth during the pandemic when all these kind of enforcement discretion waivers were put into place. So what does that mean? Basically, the HIPAA rules apply to telehealth and many of the things that we do with telehealth. But during the pandemic, OCR basically said, hey, we know that we need you to get services out to people. So we know that you're probably going to violate some of these HIPAA things. We're not going to prosecute. We're not going to penalize you during this time of the public health emergency. So next slide. So as telehealth resource centers, what we have kind of tried to do is pulled out all of the things that we have seen to date, or some of at least the top 10 things we've seen as a result of the public health emergency that pretty much violate HIPAA, but people have not been very careful about this. So things like having phone conversations with patients in public spaces and or using a speakerphone, that is a violation of HIPAA. Initiating telehealth visits with patients using shared or family devices. So, kid has a laptop open, you need to see a patient, you grab the kid's laptop, or you have a family laptop that everyone in your family uses, and so you're sharing the device. That could potentially be a violation of HIPAA. Communicating health information with patients using unencrypted email is definitely a violation of HIPAA. Texting with patients using consumer messaging apps is a violation of HIPAA. And I don't have to read all these things to you. I think you kind of get the message. Should you be concerned? Absolutely. So you have 90 days, so you have to August to get in compliance. And violations are per violation penalties. And so there's this thing called unknowing violations where they kind of give you a slap on the hand and go, hey, you didn't realize. But because you're sitting here in this presentation, you now know, so you don't have that I just didn't know excuse anymore. So unfortunately, and they are financial penalties. It could be $100 minimum per violation, all the way up to $50,000 maximum per violation. And per violation means if I am sitting here in a public park on my kid's device, having a conversation with a patient on a speakerphone or on speaker using unencrypted video, I have just committed about 7 violations. So multiply 7 times the financial impact, and that could add up very quickly. So I'm not doing this to scare you, but I am doing it to say, please pay attention, because there are many things where telehealth plays a role. So next slide. So most people go, oh, well, I'll just get a nice software that's HIPAA compliant. And I'm not going to make you do this, but I like to do this because I say, which one of these is the real HIPAA compliance logo? And people always put their answers in the chat and do a poll. And this is a trick question. The answer is none of these. There is no such thing as a HIPAA compliant logo. So every single vendor that you see will say, I am fully HIPAA compliant. They will put all these little things up there on the graphics showing that they are HIPAA compliant. And the reality is there's no such thing as a software that is HIPAA compliant. So that is number one, be concerned about. All right, so next slide. Just because they say they're HIPAA compliant, pretty much means that they think their software has encryption, end-to-end encryption. That's what most software vendors will say. Oh yeah, we are encrypted, so we are fully HIPAA compliant. HIPAA goes way beyond just end-to-end encryption. You also have to have a business associates agreement with that vendor. So if you don't have one and you're using software for your telehealth visits, you need to start looking into that now, because you really have until August to come into compliance. A business associate agreement basically says, I am delegating my HIPAA compliance to this vendor. So that vendor then has to, in their business associate agreement, basically say, I am training my staff and anyone who works with this software, anyone who might have access to your PHI. So that could be the video transmission, it could be the IP address, it could be patients' email addresses. Anyone on their staff, they have to say, that they have been trained about HIPAA. Only people who have a need to know and can get access to that information. And they have a reporting requirement. So if someone breaches that, they have to report to you and to anyone who might have been touched by that. Many companies don't have any idea that they are actually required to do this. They'll just say that we have encryption, therefore we are HIPAA compliant. It is really up to you as the provider to do some due diligence and ask the hard questions of your vendors. Don't just take their word for it that they are fully HIPAA compliant. Next slide. So HIPAA compliance is also beyond software. And I said, HIPAA controls have to do with technology. Yes, that is one part of it, but they are also physical and administrative. So your security is an ongoing process. You really need to do, and many of you probably were working in an office, and in an office setting, it's very different than in your home setting. Many of you have flipped to working from home, at least part of the time. And so on the next slide, we'll look at these are different access points where private health information gets transmitted. So if you're in an office, you're usually probably, or in a hospital setting, you're on a server that's company run. They are probably locked down. They have a security compliance officer that's looking at all of these things. But if you're at home, you probably don't have that. So you may be on a Wi-Fi that is not locked down or secure. Your neighbor could probably hijack your Wi-Fi if they wanted to. And so if you don't have those firewalls and that encryption in place, your home may not meet some of those requirements for HIPAA security. So you really need to think about all those access points. Who has permission to access your information? So if you're on a laptop and you're working at home and you leave your laptop lying around and you don't have a password protection on your laptop, you do need to be concerned, because any family member could go, your kids could come up to your laptop and go, hey, can I use the internet? They can open up your laptop and see information. Some of that could be private health information from your patients. So those are all things that you need to consider. Next slide. And I mentioned a little bit about setting differences. So if you're doing clinic to clinic telehealth, that's a lot easier, right? Because your patient is going to a clinic, you're seeing them from a clinic, and so you're relying on the security of your clinic. But if you're at home, your patient's at home, you really need to think about how are your patients getting the information. So most of us are used to using Zoom, and so we send via email a Zoom link. So we need to be concerned if your email is not encrypted and your patient's email is not encrypted, because email addresses are part of PHI, IP addresses are part of PHI. And so all of that is a violation of HIPAA if you're doing it through unencrypted communications. So obviously, if you're sending from a clinic email address to another clinic email address, that's not a problem. So you really need to think about what the setting is and where those points are. So next slide. This is what I encourage people to do. Really kind of replicate a workflow for every task where you access PHI. So it could be scheduling your patients, because obviously if you're doing scheduling, you have patients' email addresses, or you're doing text messaging with the patient, you're sending a confirmation of a schedule. How are you collecting your informed consent paperwork if you're doing paperwork, or any kind of paperwork, really, intakes? How is that paperwork being transmitted? If you're accessing your EHR, how is that being accessed? If you're doing e-prescribing, how is that happening? If you're ordering labs, how is that happening? Really think about each of those workflows, each of the places where PHI is being transmitted over the internet, and how are you locking that down and securing that on top of the video. So next slide. On our website, and also in this link here, we do have a document that's called the HIPAA High-Tech Compliance Roadmap. It's actually a really comprehensive document that walks you through what things you need to think about, what things you need to look at. So everything from the risk assessment, where is PHI stored, where, who has access to it, what are the access controls that you have in place, What staff training do you have? What policies do you have? One major piece of HIPAA is actually having policies in place. So if you have 0 policies around telehealth and HIPAA, it's probably a good time to start working on those now before August. And then what kinds of security controls, and then having some way to test. So many of us are in hybrid models and we're changing the way that we do things, sometimes on the fly. We have a new EHR that we're implementing, we're gonna do this. We're changing our software, so now we are able to bring in 2 or 3 family members where it used to be just 1. Each time you change those types of things where, maybe now we have 3 interpreters and a family member and joining, those are all access points that really you need to go back then and re-ask all those questions. Where are the risks? How has this changed my workflow? So again, I'm not doing this to scare you, but I am doing it to really say, pay attention, because we do have some changes that are coming up, and they're coming up pretty soon. If any of you work in large hospital and healthcare settings, there are some changes to Stark laws and anti-fraud things. I don't know how many of you do, so I'm not going to go into that. But if you have questions about that, please either put that in the chat and we can address that later in some Q&A, or I can definitely reach out to you and let you know some of those other things that are specific to hospitals and health systems. And I will punt to Danielle for the DEA stuff.
Excellent. Is it okay just to keep rolling, Alissa? Okay. So thanks everybody for joining us. This is some fairly intense things with, as Lloyd mentioned and Kathy mentioned, things are shape shifting over these next few months, and that these DEA or proposed rules for prescribing of controlled substances is a biggie. So we wanted to make sure that we hit on this today. And it absolutely affects genetics providers and parents and caregivers. ADHD medications, for one, would be something that fall into this category. And so it's really important that we understand what's going on here on both ends. So there are 2 different rules that were proposed by the DEA. And one is specific to Schedule 3 through 5 controlled substances, which are non-narcotic, and one is specific to buprenorphine, which is a Schedule 3 narcotic. There was an opportunity for public comment. It was opened March 1st and it closed March 31st. It was a 1-month period. We had to put these slides together for the continuing education and get them over to Alissa. And I'm like, I know there's going to be changes, but as of 4 days before comments were due, there were 16,894 comments submitted. And when it closed on the 31st, this was my update, there were over 35,000 comments. I think this might have broken a record because it's such an important facet to providing care via telehealth. And so if you have a minute and you want to view all of those comments, they're actually available via that hyperlink that says view all comments. You can actually look at the individual comments that were submitted by 35,000 plus folks on the DEA website. There were definitely, the DEA and, stakeholders believe that the proposed rules ensure that controlled substances and chemicals at risk for abuse or harm are appropriately regulated. However, there are many folks who believe that there will be increased issues with access and with a decreased workforce capabilities. It's a strong issue that many people had lots of concerns over. So many of these 35,000 plus comments were voicing concern about access moving forward. So we do anticipate that something will be finalized by May 11, 2023, unlike, the 90 days grace period for the HIPAA requirements after the public health emergency ends. There is no grace period that we're aware of right now. After May 11, these flexibilities on prescribing of controlled substances will end. So we can move to the next slide. So what is the purpose really? And I don't need to read this in detail because I know we're a little short on time here. But really it's to ensure that patients do not experience lapses in care and to ensure the continuity of care under the current telehealth flexibilities in place as a result of the COVID public health emergency. So you can see here, they're defining, and this is many thanks to colleagues at Foley and Lardner. This is where this information comes from. I'm all about not recreating wheels and saving time where we can, as I'm sure you all are, because everybody is so busy. But you can see here kind of what the purpose is, and we can go ahead and move to the next slide so we can dig into this a little bit. And this slide is thanks to our colleague Mei Kwong at the Center for Connected Health Policy, who did a great presentation on this earlier in March. But this really digs into, and this is the first rule, which impacts telemedicine prescribing of controlled substances, those Schedule 3 through 5 non-narcotics. So the current law, and this was well before COVID, had 7 exceptions under which you could prescribe controlled substances via telehealth without an in-person evaluation first happening. So if you were treating in a DEA registered hospital or clinic, if you were treating in physical presence of a DEA registered practitioner, which many folks are, if it's treatment by Indian Health Services or tribal practitioners, treatment by a practitioner who's on a special registry. Well, we've been talking about this special registry since the Ryan-Haight Act was passed in 2008, and actually it was mandated by the Support for Communities and Patients Act in 2018. However, it still has not been created or implemented. So there's some strong opinions on how that could be a very effective way for us to move forward with controlled prescribing of controlled substances, but we need to get it into implementation. During a public health emergency, which we have been in for the past 3 years, treatment by a VA practitioner or Veterans Administration practitioner during a medical emergency and other circumstances is number 7, which is really where these proposed rules from DEA are coming from. So right now, because fortunately we haven't really had a public emergency of this level in the past, but now we're trying to address what happens in the future should this happen, because currently there are no laws or regs stating what happens to a relationship formed during a public health emergency. And no in-person visit has taken place. So that's where these proposed rules are coming in, so that we have a long-term solution, hopefully, for dealing with this. So relying on that exception number 7, the DEA has proposed this rule that DEA registered practitioner can prescribe a 30-day supply of non-narcotic, that's Schedule 3 through 5, without an in-person eval, or they meet one of those 6 exceptions, or you're a VA prescriber, practitioner prescribing. So in addition, in order to continue to prescribe to that patient after that 30-day period, the telehealth provider must either have completed an in-person exam of the patient, meet one of those 6 other exceptions, or have a qualified telemedicine referral. And this is how they are currently in these proposed rules. Again, these are just proposed, 35,000 plus comments. I'm guessing there may be some changes before it's finalized. The qualified telemedicine referral is defined as a DEA registered provider, has an in-person evaluation. This could be a primary care provider. It could be a genetics physician with genetics expertise, et cetera, with the patient, and sends in their referral and all the necessary information regarding the patient to that telehealth provider. So that's how that's being defined. DEA proposes to address this by providing a 180-day grace period to practitioners to meet this requirement by either completing an in-person eval, meeting one of the 6 exceptions in the current law, or having a qualified telemed referral. So we can go on to the next slide, which covers the buprenorphine specific proposed rule. So an exception in the current law, an exception is created for buprenorphine being prescribed for treatment of opioid use disorder, which is a Schedule 3 narcotic. Again, the current law doesn't contain specificity on documentation or additional conditions a prescribing telehealth provider needs to meet, like post-PHE. So this is a little bit different. You can see a DEA registered practitioner may prescribe a 30-day supply without an in-person evaluation or meeting one of the 6 exceptions listed in the current law. And then the rest is the same as with the schedule 3 through 5 non-narcotics. In order to continue to prescribe it, they must have to complete an in-person eval or meet one of those other 6 exceptions that we talked about, or have a qualified telemedicine referral. And then in addition, for buprenorphine, the DEA is proposing to require a review of the prescription drug monitoring program data and some certain record keeping requirements. So we can go ahead and move forward, Alissa, because I know we're a little tight on time here and I want to give just a second for any questions. So here are just a few resources. Again, this is a proposed rule. So these are great resources. I know, colleagues, agencies, et cetera, will get them updated as soon as the rules are finalized. But for now, these are hyperlinks to some great resources for patients. So there's a controlled, the DEA has created a great list and for controlled substance guidance for patients and for non-controlled versus controlled medication lists. So how do I know if my child's or my medication is on this list? These are great resources to find that out. And then for providers, the DEA has also created a proposed rules summary, which breaks down the, oh my God, I can't even remember how many pages it was, but it's lengthy. So if you want to get the Cliff's notes for that, and then proposed rules highlights for medical practitioners. There's the full text proposed rules. There's hyperlinks to both of those if you have a minute and you want to read through those. And then there's a great legal guide, again, created by our friends at Foley and Lardner on the proposed rules on telemedicine controlled substances prescribing after the PHE ends. And they really kind of go into some of the interpretation and what they feel may be some important issues around access, et cetera. So with that, I'm going to go ahead and stop. I know that's kind of a heavy subject, but if folks have questions, comments, Alissa, do we have a minute?
You might want to unmute yourself, Alissa.
All right, yes, we have a minute. So if anyone has a quick question, we can do that. But I also do, as I put in the chat, encourage you guys to all become well acquainted with your telehealth resource center. Depending on where you are coming from, you may be connected with Danielle or Kathy or Lloyd or somebody else, depending on what state you're living in or territory. But any quick questions right now?
Oh, good then. Glad that's helpful.
And as we put in the chat, for the resources, the slides are posted already on the NYMAC conference website. So I know there were a lot of resources in that presentation that people really want to get their hands on. So go there and grab the slides. It's probably the easiest way, but just reach out to us at NYMAC if there's something that you were looking for you can't get. And save the chat. Yes, thank you. All right, guys. So what we're going to do now is you're going to see a link in the chat to go back to the main conference. We're going to go over there and share kind of takeaways from what we talked about together with the other session, people that attended the other session and vice versa. So find that link to the other Zoom and follow us back to the main session. Thanks so much to our speakers.
Thanks all.